the changes in actual treatment selection markers probably predate the last decade. It was the 1970s when we started using estrogen receptor to determine whether patients should receive endocrine therapy. It was the 1990s when we started using HER2 to actually see if patients should get Herceptin and other HER2 targeted therapies. And it was the early 2010s, maybe even the late 2000s, when we started to think of Oncotype DX as a potential predictive biomarker for chemotherapy. In diagnostic pathology, not a lot has changed since then in terms of what is used. The questions have changed, but the actual technologies have not changed. We're still using 1970s technology, IHC, and later maybe 1990s technology, FISH, to segregate patients for endocrine therapy or HER2-directed therapy. We understand more about a disease that has effectively not changed over time than we ever had before. We recognize that there is molecular heterogeneity within cancers, that patients may have a mixed luminal basal phenotype in their cancer, even though we might have to treat them predominantly as luminal or basal. Patients may have significant molecular drivers down a CDK pathway, down an FGFR pathway, or down a PI3 kinase pathway, or any combination of the above. We understand at a molecular level the number of mutations that exist in cancers, maybe 50 to 100 mutations in a cancer by the time it comes to diagnosis. The translation of that knowledge from concept to reality in terms of patient management has been very slow. And I think it is because we are facing a challenge in how to manage what is such a vast amount of data in the context of what is a very, very streamlined management process for patients.